Sini. Sini.
Ini nggak bisa dibantu ya? Masih semua itu belum belum pesan. Dia masih pesan. Nggak bisa pesan. Pak, saya baju nanti Pak. Nanti. Belum siap. Berapa nih? Saya oke.
Ini tinggal tunggu orang masuk lah. Oh, anu. Gak ada view ya, nyanyi aja ya.
Mau rendang atau mau bebek?
Pernah dikirim ke itu. Ada.
Assalamualaikum Bapak Ibu presenter yang hari ini akan mempresentasikan makalahnya. Kami mohon dapat mengganti nama pada Zoom sesuai dengan yang sudah diarahkan, yaitu presenter underscore nama lengkap. Sekali lagi Bapak Ibu yang presenter, kami mohon agar dapat mengganti nama pada Zoom-nya dengan presenter, kemudian underscore, dan nama lengkapnya. Terima kasih. Assalamualaikum Pak Warek. Ya, 4. Hey, Dr. Hader, can you hear me? Are you there? Dr. Hader? Dr. Hader? Dr. Hader, can you hear me?
Yes, can you hear me now?
Yes. Would you be able to start your video just to check on that?
Oh, okay. 1 second. The host is not allowing participants to unmute themselves. Is that okay?
What's that?
It says that host is not allowing participants to unmute themselves.
Oh, really? Okay, we will change the setting now.
You got it?
Yes, you're unmuted now. We have changed the setting.
Yes, and you can see my face too.
It's okay now. Or
Sorry.
we can unmute ourselves.
Right. We changed the setting already, so hopefully you guys can talk.
Okay, thank you.
Thank you, Dr. Hader.
Have you started the program?
Not yet. We are waiting until 8 o'clock, and then we're gonna start.
Okay, yes.
And Dr. Hader, please meet Vice Rector of Academic Affairs, Dr. Alfizar.
Dr. Hafiz, Assalamu alaikum.
Waalaikumsalam, sir.
Or good morning.
Yeah, good morning, welcome.
Good morning, and it is
Thanks for inviting me to this conference. Dr. Farman did a marvelous job.
Okay, you're welcome.
and Dr. Hader, please meet our dean, Dr. Darmawi.
Halo, assalamualaikum warahmatullahi wabarakatuh.
Assalamu
Salam,
alaikum.
rahmatullah.
How are you, sir?
Welcome for all. Yes,
Nice to meet you.
yes. I can hear you here.
Thank you.
Okay, thank you.
Dr. Hader, it is raining now in our place. Hopefully nothing technical problems happening tonight.
Listen, don't get panicked. If something happens, it will happen.
Right, absolutely.
Okay, so we are all mature people, we understand.
Yep.
It's a great thing that we are all getting together, and inshallah, it will be okay.
Inshallah, inshallah. And I see here there is a Dr. Moy from University of Malaya. Dr. Moy, can you hear me?
Yes, yes.
Would you like to try your video or camera?
Okay. Yeah, hi, good morning.
Hi,
Can
Dr.
you?
Moy, good morning.
Yeah,
How are
yeah,
you?
yeah.
Good
Yeah, fine,
morning.
thank you. It's
Hi.
raining over in KL too.
Yeah,
Yeah.
it's good to see you.
Yeah, I was just testing. It's very early now for us here.
Oh,
No,
really?
no. We are 1 hour late. Sorry. Yeah, yeah,
1 hour late, right, right.
yeah. Mhm.
How are you today? We are still waiting for the opening ceremony, and hopefully we can start at 8 o'clock.
What is the number of participants?
The number of participants today is actually 500.
Oh,
500.
that's great.
Wow.
500 participants, and we got about 53 or 55 presenters for a parallel session. So we have a plenary session and the main session, which is the keynote speech for you guys. And unfortunately, Dr. Ward from Australia cannot join us today because there's some things going on there. So yeah.
Okay.
The background flyer is great. It looks very nice.
Have you tried it?
Yes, I shared with my dean.
Oh, really?
Yeah, because you guys are very generous. You put University of Maryland logo. So that's
Okay.
a great publicity for Maryland.
Yeah, of course. All right, then enjoy the music for a little while and we will start soon, inshallah.
Oh, thank you.
Terima kasih sama kumpul. Di atas itu yang gitu. Iya. Tadi sampai sini. Tidak situ terus. Udah saya kirim tadi. Udah. Nanti dia. Tidak apa salah. Udah gede semua. Ini punya bisa. Apa masalah dia?
Salah, mungkin link yang lain. Tertekan yang lain.
Ada link yang lain ada.
Video muda.
Assalamualaikum Bu Feni.
Ya, waalaikumsalam, Pak.
Prof, Pak Dekan, bisa kita mulai ya?
Oke, Pak Firman, saya sudah bisa mendengar. Ya.
Pak Warek, kita mulai ya Pak. Oke, semua siap? Acara akan segera kita mulai. Ladies and gentlemen, we would like to start the agenda now, and it is the time for us to start our agenda today. Master of Ceremony, time is yours.
Thank you for the times. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
wabarakatuh.
Ladies and gentlemen, welcome to the second International Conference on Public Health 2020. With them, multidisciplinary research on public health and medicine in pursuit of SDGs and in response to COVID-19 pandemic. All praises to Allah, the Lord of the world, who has given us health and opportunity so that we can attend this virtual meeting today. Salawat salam to our beloved Prophet Muhammad sallallahu alaihi wasallam, who has brought us from darkness to the brightness. Well, ladies and gentlemen, in this good opportunity, it's a pleasure for us to welcome our speakers, Professor Dr. Mor Fong Ming from University of Malaya, Malaysia, Professor Muhyiddin Haider, PhD from University of Maryland, United States, Professor Power, PhD from Flinders University, Australia, and Mr. Abdul Ar-Rahman Trabelusi from Stanford University. And all of our special guests today, Aceh Governor, Aceh Region, and all of Head of Health Organization in Aceh. Well, ladies and gentlemen, in opening our ceremony today, let's listen together the recitation of Holy Quran that will be read by Mr. Nofriadi Ihsan. For Mr. Time is yours.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. يا أيها الذين آمنوا إذا قيل لكم الذين آمنوا إذا قيل لكم تفسحوا في المجالس إذا قيل لكم تفسحوا في المجالس فافسحوا يفسح الله لكم وإذا قيل انشزوا فانشزوا يرفع الله وإذا قيل انشزوا فانشزوا يرفع الله الذين آمنوا منكم وإذا قيل انشزوا فانشزوا يرفع الله الذين آمنوا منكم والذين أوتوا العلم درجات والله بما تعملون خبير والله بما تعملون خبير صدق الله العظيم. السلام عليكم ورحمة الله وبركاته.
Waalaikumsalam.
Waalaikumsalam
warahmatullahi wabarakatuh.
wabarakatuh. National Anthem Indonesia Raya.
Airku. Aku berdiri. Aku
Rakyatku semua. Merdeka, merdeka.
Ladies and gentlemen, now let's listen together. The welcoming remark by the conference chair, Mr. Firman Parlindungan, PhD, for Mr. Time is yours.
Thank you, Bu Feni. Can everyone hear me?
Yes, I can.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Waalaikumsalam warahmatullahi wabarakatuh.
Your Excellency, Rector, University of Teguh Umar, Vice Rector of Academic Affairs, University of Teguh Umar, Governor of Aceh, Bupati of Aceh Barat, and all distinguished keynote speakers, presenters, and all participants. As your conference chair, it is my pleasure to welcome you all in this second International Conference on Public Health 2020. This year's conference, we decided to focus on the big theme, multidisciplinary research on public health and medicine to pursue SDGs and in response to COVID-19 pandemic. We believe that this theme is relevant to what is currently going on around the globe, and it is important for all of us, especially in academia, to contribute ideas that would make this world a better place. Ladies and gentlemen, today we have 4 keynote speakers. The first one is Professor Muhyiddin Haider, PhD, a clinical professor from University of Maryland, United States. And the second one is Abdul Rahman Trabulsi from Stanford University, United States. And the third one is Professor Dr. Moy Fong Min from University of Malaya, Malaysia. And the fourth one is Professor Paul Ward, PhD, from Flinders University, Australia. Unfortunately, due to unforeseen circumstances, Professor Ward is not able to join us today, but don't worry, you guys can still access his paper and PowerPoint slides later after this conference. We will share you the link for that. This year conference, we also have 59 presenters who will present their papers in plenary session later this afternoon. All of you are welcome to join. You can just go back, click the link that we have shared to you in Zoom, and then the host or the operator will put you in the plenary sessions rooms later. Finally, I would like to thank all of the committees of the conference who have worked days and nights to make this conference successful. Without your hard work and determination, this conference would not be successful. I wish you all a good conference, and I'm looking forward to listening to all of the great speakers today, and see you next year. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
For the next welcoming speech by the Dean of Faculty of Public Health of University of Teguh Umar, Professor Dr. DRH Darmawi, MSc. For Professor, the floor is yours.
Oke, terima kasih Bu Feni. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Yang terhormat Bapak Rektor Universitas Teguh Umar, yang terhormat Bapak Wakil Rektor Universitas Teguh Umar, para Kepala Biro, para Dekan dalam lingkungan Universitas Teguh Umar, yang saya hormati Bapak Gubernur, Bapak Bupati, dan Bapak anggota Dewan Perwakilan Rakyat Kabupaten Aceh Barat. First of all, in the name of Allah, the most beneficent and the most merciful, I would like to thank Him for all the blessings He has given us, so we may live and attend the conference in a good condition. Also, may His blessing be attended to Prophet Muhammad sallallahu alaihi wasallam, peace be upon him. The Faculty of Public Health, University of Teguh Umar, is more than happy to present to you the second International Conference on Public Health 2020. This conference was initially planned to be conducted in person, where we all can gather on our own campus and enjoy the gorgeous of Aceh. However, COVID-19 led us no other option except this virtual meeting. The health and well-being of all of us are our greatest concern. This year, conference carries the term multidisciplinary research on public health and medicine in pursuit of sustainable development goals and in response to COVID-19 pandemic. The objective of the conference are to align research and practice related to public health and medicine to improve the livelihood of global and local citizens. Disseminating current issues on public health and medicine, especially issues that related to sustainable development goals and COVID-19 pandemic, and strengthening international relationship in the area of public health and medicine. As such, I would like to welcome our keynote speakers, Professor Muhyiddin Haider, PhD from University of Maryland, USA. Professor Dr. Moi Fung Ming from University of Malaya, Malaysia. Dr. Abdullah Abdul Rahman Trabulsi from Stanford University, USA. And Professor Paul Watt from Flinders University, Australia. We are grateful that your attendance to this conference would shed light on current health issues and policies around the globe. I would also welcome all distinguished presenters and participants of the conference. I believe you will engage in a fruitful discussion. I wish you a good conference. Thank you very much. That is all.
Ladies and gentlemen, it's time for us to listen the opening speech by Rector of University of Teguh Umar, Professor Dr. Jasman J. Ma'ruf, SA, MBA. In this occasion, will be presented by Vice Rector of Academic Affairs, Dr. Alfiza DAA. For Dr. Time is yours.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
My pleasure to welcoming to all participants of virtual conference. This opening speech is on behalf of the Rector of Teguh Umar University. First of all, praise to be the presence of Allah Almighty who has given health to us. So we can gather here for the second international conference on public health 2020. Prayer and greeting bestowed to Prophet Muhammad sallallahu alaihi wasallam. Ladies and gentlemen, crisis caused by the COVID-19 pandemic has affected various sectors. As confirmed, global cases are still increasing. Universities face serious challenges in sustaining its goal, including enrollment, administrative infrastructure, tuition fee, student to faculties, ratio, and cost. Universities need to take action to manage the risk caused by the COVID-19 outbreak. University of Teguh Umar, which is located in the mountain Sumatra Island in west coast of Sumatra of Indonesia, strives to become a prosperous, sustainable university. This goal is mentioned in its vision statement that is to become a source of inspiration and reference in the development of science, technology, and business in the agro and marine industries through innovative, creative, and highly competitive research. As such, UTU, the University of Teguh Umar, provide support for the COVID-19 outbreak control that is in line with the three functions of university: education, research, and social service. The second International Conference of Public Health 2020, organized by Faculty of Public Health, University of Teguh Umar, is extremely strategic in realizing its vision. Through this conference, various health issues coming from disciplinary background can be discussed. The hope, of course, is not only to disseminate knowledge, but also to find solutions to dynamic that are currently developing. I would like to say and thank you for the presence of keynote speaker. The first one, Professor Paul Ward, PhD from Flinders University, Australia. The second from Professor Muhyiddin Haider, PhD from University of Maryland, USA. The third, Professor Dr. Moy Fong Ming from University of Malaya, Malaysia. And the fourth, Abdul Al-Rahman Rabusi from Stanford University, USA. Your presence today is invaluable, especially for University of Teguh Umar. I hope that in the future, we can establish a closer cooperation between University of Teguh Umar and your institution, especially in the area of teaching, research, and community services. Also welcoming to all speakers and invited guests on campus of the Source of Inspiration and Reference. Finally, thank you for the Dean of the Public Health, University of Tucumar, Professor Dr. Darmawi, Master Science, which has directed this international conference so that it is held successfully. Thank you also to all the committee who has worked day and night for the success of the event today. Now, I open this conference by saying Bismillahirrahmanirrahim. I wish you enjoy and have a good conference. Thank you very much.
Assalamualaikum.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh.
Recitation of prayer by Mr. Nofriyadi Ihsan. For Mr. Time is yours.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين حمدا يوافي نعمه ويكافئ مزيدا. يا ربنا لك الحمد كما ينبغي لجلال وجهك الكريم وعظيم سلطانك. اللهم صل على سيدنا محمد وعلى آله وصحبه وبارك وسلم. أشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدا عبده ورسوله صلى الله عليه وسلم لا نبي بعده. اللهم اغفر لي ذنوبي ولوالدينا وارحمهما كما ربياني صغيرا ولجميع المؤمنين والمؤمنات والمسلمين والمسلمات برحمتك يا أرحم الراحمين. اللهم إنا نسألك سلامة في ديننا وعافية في جسدنا وزيادة في علمنا وبركة في رزقنا وتوبة قبل الموت ورحمة عند الموت ومغفرة بعد الموت. اللهم هون علينا في شكرات الموت والنجاة من النار والعفو عند الحساب. ربنا ظلمنا أنفسنا وإن لم تغفر لنا وترحمنا لنكونن من الخاسرين. اللهم ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. سبحان ربك رب العزة أما يصفون وسلام على المرسلين والحمد لله رب العالمين. السلام عليكم ورحمة الله وبركاته.
Waalaikumsalam
Warahmatullahi wabarakatuh.
Ladies and gentlemen, with the end of the recitations of prayer, it means that the opening ceremony finished. I am, as the master ceremony today, would like to say thank you very much for your attention and participation. Sorry for the mistake. Finally, I say for you, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
warahmatullahi wabarakatuh.
Okay, for the next agenda will be led by Mr. Firman Perlindungan, PhD. Enjoy the conference, ladies and gentlemen. Thank you.
Thank you, Bu Feni. That was a great opening. Thank you, everyone. So before we proceed to the keynote speakers' presentations, I would like to allow us all to have a short break for about 10 minutes. Maybe you guys would like to grab some coffee or tea before we listen to our great speakers. For our first speakers today will be Professor Muhyiddin Haider, PhD. But before that, let's take a short break for about 10 minutes. Please enjoy your coffee.
Yeah,
Well,
enjoy your coffee at home.
yes, at
Thank
home.
you.
All right, ladies and gentlemen, while you are enjoying your coffee, I think we can start the agenda for today, which is keynote speakers presentations. And for the first keynote speakers uh, today is Dr. or Professor Muhyiddin Haider, PhD from University of Maryland. He will be talking about multidisciplinary research approaches to achieving universal healthcare in Bangladesh. Before I introduce him, I would like to welcome the head of Indonesian Public Health Association, or IACMI, who has joined us today in this agenda. Ladies and gentlemen, let me introduce to you all Professor Muhyiddin Haider. He is a clinical professor in global health in the University of Maryland, School of Public Health Institute for Applied Environmental Health. Since 2009, he has been teaching undergraduate courses under the Public Health Science and Global Health Scholars Programs, while also teaching graduate level courses in the Global Health Certificate Program offered through the University of Maryland School of Public Health. In addition to teaching, Dr. Haider is currently a co-investigator of Project HEAL, Health Through Health Early Awareness and Learning, and interventions to increase cancer screening in African American faith-based communities in Prince George County, Maryland. He is also the principal investigator on a study to assess the U.S. Public Health Service Commission's corps officers' value to public health. Dr. Haider is a highly skilled public health professional who has managed and led diverse public health projects and research studies in more than a dozen countries worldwide over the past 30 years. On behalf of several international agencies and universities, he has assisted multi-sectors initiatives to advance the delivery of quality healthcare services in the areas of avian influenza, HIV/AIDS, TB, RHFP, malaria, and has developed expertise in the areas of health communications, health promotion, health education, and social marketing. His research into strategies of behavior change, applications of social marketing tools, and communications capacity building has led to several acclaimed publications. He has led major public health projects in several countries in Africa and Asia, for which he utilized technical skills to stimulate innovative and culturally sensitive approach grounded in organizational and technical soundness. His recent research and programmatic work has focused on avian and pandemic influenza, for which he has contributed to creating and adapting IEC, BCC, and IPC training materials to establish and implement best practices within public healthcare system and promote public-private partnership. Without further ado, I would like to invite Dr. Muhyiddin Haider to present his paper. Dr. Haider, can you hear me? Dr. Haider? Dr. Haider?
Can you hear me now?
Yes, yes. We can hear you clearly now.
Okay.
All right.
Thank you.
Ladies.
Thank you, Dr. Furman. That was a really long introduction. I appreciate very much. Ladies and gentlemen, Assalamu alaikum. Good morning. Before I start my delivery, somebody was trying to tell me something.
No, you can go ahead.
Okay, before I start my deliberations, I would like to appreciate and thanks to the organizers of this conference. It's really great privilege for me to know my colleagues in Indonesia and abroad, and also the great citizens of Indonesia. Next slide, please. I have a very ambitious outline. Before I go line by line, let me summarize what is my main argument, what I would like to present today. I would like to argue that universal healthcare needs multidisciplinary research approach. The question is, in order to prove my argument, I would like to use examples from Bangladesh Health Facility Survey to show the data that why do we need multidisciplinary approach in pursuing universal healthcare. Next slide, please. Universal healthcare was prompted through Sustainable Development Goal number 3, which ensures healthy lives and promote well-being for all ages. And it requires coverage, financial risk, protection, and access to quality essential healthcare services, and to safe, effective, quality, and affordable essential medicines and vaccines for all. Next, please. What is universal healthcare? Everybody knows it's a WHO concept. WHO also provided the framework, but based on Sustainable Development Goals 3.8, universal healthcare is characterized by three components. These components are protection from financial risk, access to quality healthcare, and access to essential medicines and vaccines. Next one. The importance of universal healthcare is defined through the following argument. It recognizes health as a human right, like all other human rights. It ensures primary and emergency health care for everybody, regardless of gender and age. It increases and expands citizen-centric quality health care, ensuring equity. I will come to the equity issue later. It enables people to seek health care and undertake healthy lifestyles. It also improves public health and nutrition. Universal healthcare can strengthen the health systems and progress in other health-related goals that started with Millennium Development Goals. In WHO framework, we see there are identified different system building blocks, and by using those blocks, what kind of outcomes universal healthcare would like to achieve. The blocks are service delivery, health workforce, information, medical products, vaccine technology, financing, leadership, and governance. And the access, coverage, and quality safe provides this outcome or help to produce these goals and outcomes. That is improved health in terms of its level and also in terms of its equity. Healthcare must be responsive to the people's needs. Also gives social and financial risk protection. Definitely, it needs to improve efficiency. Next slide. If we take that framework and put into this kind of paradigm, we start with the service delivery. Service delivery needs human resources. It needs medicines. It needs financing. It also needs high-level access to information. All these elements under service and delivery should have a positive and productive leadership and governance. Next, please. Sustainable Development Goals also provide some indicators how to monitor universal healthcare. To support health system framework and to monitor progress towards universal healthcare, WHO established two indicators within Sustainable Development Goals. One indicator provides the coverage of all health essential services. The second indicator gives a proportion of the population with a large household expenditure on health as a share of total household expenditure or income. Next, please. Now, I just stated very briefly the conceptual aspects of the universal healthcare and its essential framework in relation with Sustainable Development Goals that WHO outlined. Now, here is my example from Bangladesh health system and its health facility survey. I will not go in details about the survey report because that is not the primary objective of my presentations. My primary objective is to provide some illustrations from the survey and show why these illustrations give emphasis on multidisciplinary health research system. Before I go to the survey results and focusing on certain data, I would like to give a brief introduction to Bangladesh health system. It's a pluralistic health system to implement programs and policies developed for national standards. Every 5 years, Bangladesh government reviews health system performance and also try to identify the gaps and provide suggestions for the next 5 years program, which is the guiding principle for government donations, foreign investments, and donors funding and other individual donations. It adheres to WHO defined universal healthcare criteria. The leadership in Bangladesh health system is very much committed to improving health system. Many unique challenges remain. Economic insufficiency and overpopulation has led to health services to experience overcrowding, understaffing, shortage of qualified professionals, and disproportionate allocation of resources between rural and urban areas. This is one of the significant limitations under Bangladesh health system. Next, please. Now, how service delivery is a part of health system, or on the other hand, how service delivery works under Bangladesh health system. The services are provided through the network of organizations. These organizations belong to government, for-profit private sector, non-profit NGO sector, and international development organizations, including donors. The system is divided into district levels of service delivery to provide all essential services as a primary service, secondary service, and tertiary service. Primary services belong to local government. In Bangladesh, they call Upazila health complexes, community clinics, union health, and family welfare centers. The secondary includes local maternal and child welfare centers and district hospitals equipped with specialist services. Tertiary is the national hospitals, medical universities, especially hospitals, and medical college hospitals. Here is some examples I would like to give based on facility survey data, as I mentioned earlier. The report that I'm talking about is based on 4th National Health Service, produced by the National Institute of Population Research and Training, called NIPORT, with a technical assistance from US-based companies called Icph, International Collaboration Federation. It's funded by government of Bangladesh and also USAID, United States Agency for International Development. The survey has a huge number of data, collected extensive structural and input data to assess the availability of basic and essential health care services and facilities throughout the country in 6 health topic areas. And these health topics areas primarily child health, family planning, antenatal care, delivery and newborn care, non-communicable diseases, and tuberculosis. Those data were provided and compared by facility type, by providers, and by the facility location. Now, the kind of facility data we got under these topics is not enough, because these topics, particularly services, cannot be explained by only infrastructure level data which the survey report provided. I will come later. Why do I think that comprehensive or multidisciplinary health research approach would be needed in order to understand these health topics and how these health areas are dealt with the government and the health service delivery facilities, and also in general health professionals. Next one. Survey showed certain strength at the organizational level and also the weaknesses. One of the strengths is of this survey, it gives in-depth overview of the health system in Bangladesh and this management structure of facilities under Deputy Generals of Health Services. It provides data of the locality of services and also role of facilities. This data can be used with mapping and census to determine needs and accessibility. Although this is a strength, but I would like to come back to these points later and show these strengths are very limited, because health survey doesn't provide comprehensive multidisciplinary research approach in their report. The weakness, one of the major weakness, that the survey doesn't provide additional information on the organization of facilities, how these facilities are organized, how the management structure is given, how the supportive components are provided to the service deliveries, and how many populations are covered by each facility, etc. Data presentations is not uniform throughout the document, making comparisons disproportionately, because all those facilities were located into 8 divisions in Bangladesh, and development level achievement of each divisions are quite different. It doesn't elaborate division of service delivery levels and the distribution of facilities by the districts. Next one. The survey results also provide some lights on the guidelines and the policy. Those are relevant to the essential health services, particularly for child health, delivery, newborn care, and tuberculosis. It creates a standard to ensure compliance and quality of services from health facilities by discussing the results in relation to established policy guidelines. Now, here is another limitation. Although it is quite a strength that the guidelines are provided, but all facilities' ability to follow the guidelines are not similar. Because of the presence of the facility, that doesn't mean guidelines are totally followed. That also requires multidisciplinary approach research in this regard. The weakness, the survey also gave a discussion on guidelines and policy for diagnostic and treatment for non-communicable diseases and improvements to family planning services. No information is given for antenatal services, and no additional information was given on training and guideline compliance. If we look at these weaknesses, we realize that these weaknesses shows how the different disciplines at the multidisciplinary level can be helpful to understand the service quality and also service coverage. Next one. Now here is my summary of the success that according to the health survey. It availability of services within different facilities throughout Bangladesh. It gives a partial assessment. The assessment doesn't give a proper measurement of quality of services and its relationship with the coverage in the population. It acknowledges shortcomings, particularly the areas of improvement that require in order to universal healthcare. Some sections provide recommendations to improve categories with the low availability of readiness. That means services are provided by different facilities. Every service cannot, so facilities cannot provide free services. It also requires some co-payments from the pockets. And how the poor population will have access to those services where co-payment is required, it is not defined. It is not clearly understood because there's a lack of multidisciplinary research in the report. There is a differences shows between 2017 and 2014 services. Tables also provide a comprehensive explanation of the data being measured. It provides substantial information on the presence of health services for future evaluation and research. Let's try to come back to this point when I said future evaluation and the research to utilize. That research also requires to emphasize multidisciplinary approach in the research framework. Next, please. The present report shows various inconsistencies in providing the information, particularly the effectiveness and accessibility of service. Effectiveness and accessibility service cannot be measured by the presence of the facilities. You need to look at population and you need to look at their socioeconomic conditions, plus you need to look at their ability to get access to the services. The survey doesn't provide any information regarding patient load, timeliness, and utilization of services. Patient load is very important because how much facility can carry the patient load and how patient loads are distributed within the working load and how the patient load is carried out by the health service providers, that is not very much identified. And the relationship between patient load and quality service has been defined by multidisciplinary research approach. The next is that data categories in the different chapters are not very much explained because categories may belong to different variables and different segments of population. Second, financing system was not addressed by the report. And this financing system requires a thorough methodological tools drawn from the different disciplines. It is not a job of the accountant to see the financial strength. It's also job of the anthropology, economics, and also public health, see the how financing systems provides health equity for overall population. Next one. The survey provides some conclusions. This survey, as I said, did not present adequate data to meet the criteria of the universal healthcare. The criteria that I stated before, 3 criteria. It provides very limited information on service availability, making integration with policymakers and researchers very difficult. And scientific data research can be informed and support policy evidence on the impact of current healthcare policies and practice on the population. Definitely, the Bangladesh Health Facility Survey 2017 demand for a multidisciplinary approach and research, as I have been showing where is the gap and how multidisciplinary research can be applied. And how multidisciplinary approach can show how to fulfill the needs of universal healthcare as WHO outlined. Next, please. Let's have some kind of concluding agreement. What do you mean by multidisciplinary research? By agreement, I don't mean that everybody has to agree whatever I'm saying. Agreement might provide some arguments, poses some issues, but it can provide a starting point how to strengthen multidisciplinary approach in order to achieve universal healthcare. In the textbooks, interdisciplinary research said is a mode of research by teams of individuals that integrates information, data, techniques, tools, perspectives, concepts, and or theories from 2 or more disciplines or bodies of specialized knowledge to advance fundamental understanding or to solve problems whose solutions are beyond the scope of a single discipline or area of research practice. It's a broad-based definition of multidisciplinary research, but there are key points I would like to mention here that multidisciplinary research brings some integrity of information data. It provides broader knowledge to advance fundamental understanding. And also, it opens up research practice and utilization of research in providing the services. Through utilization of multidisciplinary research, each component of healthcare infrastructure can be strengthened, and as the expertise from different healthcare applied to solve issues within each component of healthcare. And multidisciplinary research also provides opportunity to share diverse ideas, and collaboration can help identify shortcomings that were previously not considered. Next, please. Here are some recommendations how to proceed with multidisciplinary research. Studies and surveys showed to evaluate progress of facilities, including timeliness of service, quality of care, patient load, and the health financial system. Let me give some example of the quality of care. Quality of care, it just cannot be defined by technical meaning of the quality of care by the providers. Quality of care must be defined by the patients, what they think and how they define their quality. Second, cost benefit analysis. That how to make each health facilities independent, how it can reduce the burden of the grants or help from the government, how it can be sufficient through earn money based on their business and their services. Integration of multidisciplinary research approach to best advocate and represent diverse population, where creating policy that will provide effective solutions to achieving universal health care. How to address diverse population in the healthcare, it has been emphasized by many anthropologists in the different countries. Multidisciplinary approach provides emphasis on multisectoral stakeholders, because multidisciplinary approach shows how different stakeholders should be brought in the health services, around the health facilities. Those stakeholders can come from economics, from policymakers, they can be ethnographers who provide a pictorial description of the population, also healthcare workers, and overall public health goals. And these cumulative stakeholders or multi-sectoral stakeholders can address the challenges such as financial burden and public distrust. Now, multi-sectoral stakeholders is not that easy to brought in. I have my own experience when I was dealing with avian influenza in South Asia. It was very difficult in the beginning to bring two ministries together, Ministry of Livestock and Ministry of Health. Avian influenza started with livestock because chicken was dying and chicken was a part of the business and part of the national capital formation. So the private sector was worried. Government has to come forward to do something with them. Then when we found that carrying chicken is not enough, chicken can also infect the human beings, then we went to the Ministry of Health. The first question is that each stakeholder will ask the question, where is my budget? How much I am getting in involving this kind of multidisciplinary, multi-stakeholders interventions. So from the very beginning, we need to know who are these multi-sectoral stakeholders, what kind of services they can offer, how their needs can be met, and how the project interests can be given the priorities based on their objectives and their policy. Next slide, please. Here are some references I have mentioned. I know that I did not provide adequate explanation on the multidisciplinary approach or multidisciplinary research. I try to show the brief explanations based on the research results in Bangladesh, but definitely This survey data proved once again that why do we need multidisciplinary approach in order to achieve universal health care as per WHO policy and programs. Thank you very much.
Thank you, Dr. Haider. That was a wonderful insights from the side of Bangladesh. And you have explained so much about how the healthcare condition in Bangladesh, the system, the service, the delivery, and also some recommendations to conduct multidisciplinary research on the healthcare to achieve the universal healthcare. Well, we still have time actually for about 20 minutes. Maybe I would like to invite some questions from the audience before we move on to the second keynote speakers, who will be Abdurrahman Trabolsi. I think he's not joined us yet, and I think we can open a question and answer to Dr. Haider. Untuk Bapak Ibu yang ingin bertanya, saya persilahkan bisa mengacungkan tangan, raise hand. You can use your raise hand feature in the chat, or you can directly speak and unmute yourself. Okay, we got one questioner from Rosmita Sari here. Let's hear Rosmita. Rosmita? Oh, okay. Cancel. Okay, we got one from Susi Sri Wahyuni. Ibu Susi, can you hear me?
Yes, sure.
Okay, go ahead.
Okay, thank you for opportunity. Good morning, Mr. Muhyiddin Haider PhD. Thank you for.
Louder, please.
Hello.
Yes, I can hear you now.
Okay, okay. Thank you, Mr. Muhyiddin Haider PhD, for attending in the second international conference of Robial University of Oman. Like this, I see your presentations. We know sustainable development goals is ensure healthy life and promote well-being for all at all ages. Universal healthcare is characterized by three components that ensure all people can access affordable and equitable essential health service without facing economic challenge. One of these components is protection from financial risk or downfall for accessing health service. I want to know to what extent has Bangladesh been doing for this component? Okay, thank you.
Okay. Thank you, ma'am. It's a very good question. Do you want me to answer diplomatically or you want to answer me honestly?
Maybe both.
Maybe both.
Yeah.
No, I have to be honest because if I be diplomatic, she will catch me. The thing is that, listen, the Bangladesh Health Service, theoretically, it is free for everybody. Okay? But in reality, it is not. Let me give one example of the polio vaccine or overall vaccines. It's supposed to be, vaccination should be free for everybody in Bangladesh. The vaccination is controlled by the government. But in reality, I know when mother enters with the child at the gate of the hospital or the clinic. By the time she goes out after vaccinated the child, you know how much she spends? $6. It comes from the pocket. So in theory, we call it public sector free, but in reality, there is a co-payment that everybody paid, either in terms of bakshish. Do you know the word bakshish? It's some kind of bribe, some kind of payment. So now my argument was with Bangladesh, why you cannot make vaccination private sector oriented. If the private sector introduces vaccine, it will cost $3 to $4. So through private sector operation, they can save, customer can save $2 per vaccine. Now, it is not that easy to change the policy like many other developing countries. Some pilot projects started in Bangladesh to see the public-private partnership, but still vaccines are controlled by the government, and they have their own arguments why they have to control it. Because vaccines are provided by Gavi, based in New York, Global Association of Vaccines International, and they collect the vaccines from 12 or 13 companies, and government doesn't need to go to each company for each vaccine. They can go to Gavi and get all the supplies facilities at one time. So to answer your questions, it is not totally free. Okay. Now the second question comes, yes, maybe service is available to certain degree in certain areas. When you go around the capital, services are better because most of the qualified health workers live around the capital. Okay. Just recently, Prime Minister of Bangladesh has ordered to construct 459 health clinic facilities around Upazila, local government, and in the districts. Now, also there is a law that before you get the medical degree, you have to serve the rural facilities at least 2 years. Is it happening? No. They go to rural area, sign the timesheet, they come back to Dhaka because the family live there. You cannot just blame the health service providers because those local areas are not developed to take care of the family, to take care of the running water, to take care of the electricity, to take care of the sewer system. So unless you see the impact of development across the board, just healthcare sector cannot provide adequate services. That's the reason sustainable development goals is more integrated goals. And in order to achieve health goals, you need sustainable development goals, which goes outside of health. Did I answer your question? No, don't be polite. You can shout at me if I didn't answer you. Thank you. Any other question?
Yes, we got one more questioner from Ibu Arfa Husna. Ibu Arfa, can you hear me? Ibu Arfa?
Yes.
Ibu Arfa Husna?
Hello. Yes. Hello. It's here.
Hello, I'm here.
Okay, yeah, go ahead.
Okay. Thank you, Mr. Firman. Hi, Mr. Haidar. I'm Arfa Husna from FKM UTU. Universitas Tengku Umar. I want to ask about the pandemic in your country. Is there a lot COVID-19 case in Bangladesh? If a lot, what is the role of research in Bangladesh in preventing the spread of COVID-19? Thank you.
Okay. This is very good question, madam, and this is very timely. I'm trying to answer it partially because I'm not very familiar with the latest data from Bangladesh. I got some reports. The number is still modest. The death rate is, I think, around certain hundreds. But I have problems in understanding the data because sources of data collection is not very clear. Did government appoint additional workers, either health or outside of health, who can collect data and who can disseminate information? It's all coming through Director General's Office of the Health Services. So, but one good thing in Bangladesh, what is happening is community resilience. You know, Bangladesh is a small country with highly populated area. It faces natural calamities since it is born, and community doesn't have great expectations from the government. They take care. Okay. Bangladesh also, community resilience is built on the past performance or success achievement, which one of the examples I can give from family planning. Now here, Bangladesh also learned many lessons from Indonesia in 70s regarding family planning. You may not know that under family planning program, Bangladesh recruited 65,000 village workers as a volunteer to promote family planning in the rural areas. Now, these volunteers did not disappear. They are coming back in order to promote wearing the mask. There's a success of the WASH program, water and sanitation program in Bangladesh. And through WASHER program, health hands cleaning is quite promoted. But the thing is, for hand washing, you need access to water, good water. You need access to soap. You need access to clean towel. So how many, there are 60% population are, no, I'm sorry, 40% populations are poor. Where they will, do they buy a soap or do they buy a piece of bread for their food? So I think in Bangladesh has gained a lot to raise the per capita income, which is almost $1,400. When I was growing up in Bangladesh, the per capita income was around $100. Now, this high level of per capita income is an indicator that Bangladesh, everybody has gone rich in Bangladesh? No. Bangladesh didn't achieve that kind of results because the per capita income is the average of the rich income and the poor income. So it's very difficult to show how many poor people are getting access to COVID testing and tracing. Okay. Now, the Bangladesh, one good thing is the Bangladesh that all governments, including military and the civilian governments, everybody is giving emphasis on health. The health sector budget has not been increased tremendously. It is now 16% of the total budget, which is a good sign of the progress. Prime Minister is very much committed to maternal child health. The other good thing is that in Bangladesh, the secondary education among women in Bangladesh has gone up. We know from the various research that when mother is getting educated, is health literate, child survival ratio goes up. Okay. Bangladesh religious community is also majority are also pro health interventions. So they are showing sympathetic attitude towards COVID-19 patients. But I think Bangladesh has 2 million mosques, and this mosque can be adequately utilized to prevent and to trace COVID. All right. And this mosque and the community should come with a joint strategy, and prayer should be vehicle to provide messages for the protection and for the prevention of COVID.
All right. Thank you, Dr. Haider. If you could,
Thank you.
if you could hang around, that would be great because we will have another question and answer session at the end. And let's move now to the second keynote speaker, who is Abdul Rahman Trabulsi. Abdul Rahman, can you hear me?
Yes, hello.
Hello, hi, assalamualaikum.
Walaikum salam.
How are you?
Good, alhamdulillah.
Good to see you again.
You as well. You as well.
Yeah, ladies and gentlemen, allow me to introduce to you Abdul Rahman Trabulsi. He is currently a doctorate of medicine at Stanford University, and he has a broad of service experiences, one of which is a refugee organization, a non-profit dedicated to empowering adolescent refugees toward higher education, and also Stanford Muslim Medical Association, Stanford Muslim Student Union, COVID-19 Community Outreach Response and Physician Support Program, which is a weekly check-ins with high-risk patients and follow-ups with physicians preceptor, and also Stanford Transformative Experience in Medicine, which immersing high school students in STEM experience and providing mentorship. And also Union of Medical Care and Relief Organization, Medical Triage and Clinic Volunteer, Special Education Clinic Volunteer, and a Quality Improvement Director. Abdul Rahman has received a number of awards and honors, including Knight Hennessy Scholars, Rhodes and Marshall Scholarship finalists, Marcus L. Uren Fellowship, OSU Kaplan Humanitarian Award, OSU Commencement and Alumni Graduation Feature, Undergraduate Award for Excellence in Student Service, Pelotonia Fellowship, OSU Eminence Fellow. And he has also published some research in reputable journals, including a consensus framework for the humanitarian surgical response to armed conflict in 21st century warfare, and then human AML activate the aryl hydrocarbon receptor pathway to impair NK cell development and function. And its current publication in 2020 is a survey on facial trauma wound management. And Abdur Rahman today will talk about the implementing a sustainable energy solution to support medical infrastructure in war-torn Syria. Without further ado, ladies and gentlemen, please welcome Abdur Rahman Travelsi.
Hello, assalamu alaikum everyone. Thank you for the introduction. Definitely makes me sound much more impressive than I really am. And thank you for inviting me and having me here. You know, subhanAllah, with Zoom, we're able to interact kind of across the globe. So it's nice to be able to speak to you and learn from everyone here, and hopefully share something from my experiences that we can all benefit from, or just gain insight on something we haven't heard on from before. So I'm gonna share my PowerPoint. Let me see, make sure I do this properly. Let's see how I can make it work. Okay, share screen. Okay, what do you guys see?
Yes, you can see the title at the front page.
Do you still, did it change screens right now?
Yes, it's a map of Syria now.
Okay, perfect. All right. So I'm kind of taking a different approach on this for the talk today. Furman reached out to me regarding, you know, public health issues and how current things that are going on that we're working towards reaching, you know, development goals, UN development goals, or helping combat the pandemic, the COVID pandemic. And I studied biomedical engineering in undergrad. And one of my involvements while I was in Syria actually was seeing how we can leverage sustainable energy, specifically solar energy, to help maintain the hospital infrastructure in the field hospitals that we were managing. And that's kind of what I'll be briefly talking about today, and the ways that engineering and other technology solutions can help us also prop up the medical infrastructure within regions that are low resourced. So the project lead wasn't actually myself, it was a friend of mine named Talal, and I worked with him on this project, and it was through the Union of Medical Care and Relief Organizations, which is a nonprofit that's based in Turkey and does a lot of work in northern Syria managing field hospitals, mental health clinics, primary care clinics. And I spent multiple summers working with them. So as you can see, this is a kind of at the very onset of the conflict, the electricity usage and the light, if you took a picture of Syria at night and you could see kind of where it was lighting up, this is how it was before the start of the conflict. And 2 years later, as the conflict progressed, you can see how much of that light pollution decreased, which was a sign of electricity being cut to many different places. Electricity became much, much less common in different areas in Syria. And as a hospital working in Syria, we needed electricity. Within the medical field, you have to be able to sustain ventilators for people who can't breathe on their own, incubators for babies that are premature. There's many reasons we need electricity in a hospital. And so it became a very ongoing problem, and we had to start relying on diesel for energy. Now, to get into that, just to kind of paint the backdrop of everything that's going on, and I'm sure, you know, we've been following what's been happening for the last 10 years, but to kind of paint a personal picture and show you just how things have transformed. Here are two images of, you know, Syria before the conflict. And on the right specifically, this is actually a street that I used to go to every summer. I'm originally from Syria. My parents are. I was born in the United States. And this is a street that I would walk on almost every morning. I would go pick up milk from the grocery downstairs. And so when the conflict started, you know, these scenes that I was very familiar with slowly transformed to this. And just like complete ruin of different homes, hospitals, attacks on, you know, mosques and schools and hospital infrastructure. And the street I always used to go on, I actually found a picture of the same street. And this is what it looked like after the attacks on Homs, one of the cities in Syria. So you can see it's the same exact street, just after, ravaged by conflict. And we often focus on the human impact on conflict and the homes and the civilian infrastructure. But there's so much we can do. We might feel frustrated or desperate with everything that's going on, but we can control what's within our capacities. We can't control what's outside of it. And alhamdulillah, I felt like I had a responsibility to use some of my skills to think about how we could implement a project to help the medical infrastructure take care of the people going through this. So back to the issue with us having to rely on diesel fuel for the hospital is that when diesel supply routes were shut down, it really forced us to shut down critical services that were being provided at the hospital. The ICU, the intensive care unit, wouldn't be able to function if it doesn't have running electricity, whether it's coming from electrical lines or from a generator that we're using diesel for. So it becomes much harder for us to sustain critical services that are necessary to keep people alive. It also was actually fueling the war economy. And what I mean by that is at the time in Syria, and this has changed in the last couple of years, but at the time, ISIS, Daesh was controlling a lot of the diesel in the north, and they were selling it to make profit. And the oil lines were running through the areas they controlled. Whether it was controlled by the Assad government at the time or Daesh, we would have to buy oil to run our hospital. And the money that these entities were profiting from, they were using to supply their own incentives in the war. So we were feeding into that system ourselves by having to rely on diesel. So finding alternative energy sources would be really beneficial to cutting off that cycle. And lastly, it's high cost. Diesel was not cheap. It was very expensive. It still is very expensive. And as a nonprofit, you have limited funds and you have limited allocation of those funds. And it was taking a lot of money to sustain and put a lot of pressure on us to sustain our critical infrastructure by having to always supply diesel to our hospitals. So why solar? We thought about different solutions and we came up with the idea of implementing solar panels. So the first thing is, it was a very clever way to take advantage of different grant and funding opportunities to come up with an innovative solution that we could get funded. To get like a solar panel project funded at the hospital, which otherwise would be impossible with our budget. And rather than like convincing donors to fund us, we were able to, apply for grants to actually have this project together. But in a larger picture, it helps us disengage from that war economy, right? It helps us disengage from purchasing fuel from groups who are trying to destabilize the region. It also gives us sustainable energy when electricity gets cut out, when diesel shortage happens, right? If a diesel shortage happens, now we have something a backup we can run on. We have energy that we have stored from these solar panels that we can run on and continue to help save people's lives and manage the medical infrastructure. Bab al-Hawa is responsible for both operations as well as public health efforts like primary care services. So it's a really critical thing to keep operating. So our first step was to kind of identify a location to do this project, as well as conduct a risk assessment of it. And as you know, in Syria, Bashar Assad and the Syrian government was targeting hospitals as locations, were very vulnerable locations. And it was very risky to kind of implement a very expensive project within Syria because there's always the risk of a hospital being bombed. So there's actually one of the largest field hospitals along the Turkish border called Bab al-Hawa. And the reason it was a safe location was because it was so close to the Turkish border. Any entity that tried to attack that area, there'd be fear of retaliation from the Turkish government. So it was a very safe place for us to conduct this. It was also probably the most crucial place for us to do this. Because it was the largest hospital and because it was the safest, we were able to manage a lot of trauma in that area. So any trauma that came out of Aleppo or Idlib in that region, it would come to Bab al-Hawa hospital. And alhamdulillah, we were able to manage that at this hospital. So it was a perfect place to kind of implement a pilot project and see what we could do. So kind of little details, those who might be engineer inclined, I just want to share with you. So we had the solar photovoltaic system, or basically the solar panel system, and you can see kind of seeing the picture behind. We laid it on top of the roof of the hospital, and it was comprised of 480 panels, 288 batteries, and it had a hybrid control system so that we could allocate both electricity that was coming in from diesel sources, as well as energy that was stored in these solar panels and allocated to the hospital, so that we weren't using all the energy, but only using it when we needed it to. And we did this for a couple of months, and we collected data, and then we kind of saw, we implemented the project, we recruited people to build the panels and everything, and we were trying to see how much energy we were saving. So these are kind of the results that came out of our first 4 months where we had some stable results. And this was back in comparing 2016 to 2017, so about 3-4 years ago. And you can see our diesel usage kind of dropped significantly. Some months it was by over half. Some months was closer to 40%. And the details are on the right. But you can see it was also saving us money, right? Aside from allowing us to sustain critical infrastructure when there were shortages of electricity and diesel, it also was saving money that we could then pump into other services. And because we were able to get this project funded by a grant, it didn't cost us much from our internal funds to start this project. And we were able to kind of funnel these funds into building larger capacity. One of the things that we were working on at the time in 2017 was actually looking at how to expand our specialty services. So bring in more specialty services like orthopedics and ophthalmology for the eye. Eye injuries are very common in war, as well as like bony injuries. So having people who specialize in these things so they can provide services, as well as kind of extending out and training community healthcare workers to be in the more rural areas where we can't access as frequently. So creating like training services for community health workers to operate in those regions. Next. Okay, so kind of in terms of the summaries of what we were able to kind of during that first pilot was annually we saved more than 250 milliwatt hours of power, and the diesel savings was about $80,000 to $100,000 annually, which for our budget was about at the time about 10%. It was over $1 million that we were kind of every year being pumped into the field hospital. And just to kind of translate that to things that we can relate to on a health level, this hospital was operating about 900 operations on a monthly basis. We were seeing about 4,000 patients every month coming through the emergency room area. We had a blood bank center, right? So there was a lot of services being offered, and all these services we were able to maintain consistently because we were able to kind of help implement these solar panels, make sure that none of these things are ever at risk of being cut off. There was a time in 2015 when ISIS actually cut off the diesel supply routes, and we didn't have electricity to this area. And we had no way of getting the electricity in the hospital. We actually had to intervene with the Turkish government, and overnight there were meetings that allowed emergency deployment of oil over the border. And it was just it was a big mess. It was very stressful. So we were able to avoid that and make sure that these things that are being offered to people, these operations and the ED visits and the ICU is able to continue operating. However, of course, there are limitations. The solar energy panels are not sustaining the hospital 100%. So we're not completely 100% energy sustainable. It also is that the panels are at risk of theft. They are expensive pieces of equipment. So we've always had security guards in front of the hospital, but it's still one more thing that isn't, you don't have to enter the hospital, it's on top of the hospital. That's another thing that could be stolen, right? And this is actually something that limits our ability to potentially, at the time, think about how we would expand to other regions of Syria, where we can deploy other solar panel infrastructure to help sustain smaller hospitals, is the risk of it being stolen. And then you have to have more security and make sure that you have security 24/7. So These panels are always going to be there, whether there's people at a primary care clinic or not, the panels are always going to be set up there. So finding ways to do this in a safe way within a conflict region, and this was also an exception for us, right? This location was safe, but other locations in Syria were always targets of bombings. So investing a huge upfront cost in solar panels might not be the smartest move when we have when there's always the risk of them being torn down right away, and with the understanding that they are being specifically targeted. So at the time in 2017, things have changed a lot recently in the last couple of years. We wanted to expand the solar panels to other hospitals in Syria. However, since then, in the last 2 years, actually, there's been a huge shift in how we're thinking about technology solutions in Syria, and we've been doing a lot more telemedicine. We've had training centers that we've opened up, kind of telecommunication centers, like with training for doctors in Turkey, communicating with community health workers in Syria on the ground, to train them on to handle basic primary care visits. Although it's a conflict, we often think about trauma. We think about someone breaking their arm or bleeding out or having a bullet somewhere. But it's still, chronic problems still exist everywhere, and they become heightened in a war environment. They become heightened when you're in a situation where you don't have access to healthcare, where you don't have access to medication. These are all things that get worse. And the conflict now has been going on for about 10 years. So there's a huge buildup of chronic issues that haven't been attended to. So we've focused a lot more on the primary care aspect of things, and telehealth has been a huge component of that, to get training to people inside Syria and allow them to interact with patients in areas that are more dangerous that we can't get our own staff into. And lastly is, I really believe that sustainable energy solutions and things of this nature, they do empower local communities. When you build projects like this, you're hiring people from that region, you're investing in the local community infrastructure, you're not bringing outsourcing work from the outside. Same thing with these telehealth opportunities that we're training community health workers. We're not paying someone to fly over from another country and work within Syria. No, we're training people that are from the regions who've lost family, who've lost livelihood, who've lost their income and their sense of home, to contribute back to building that sense of home. So I think there's a huge benefit in sustainable energy solutions, as well as other ways of finding ways to empower local communities to take initiative rather than outsourcing it from the outside, which we here in the United States do a lot, unfortunately, where we go into other places and kind of impose our will of what we think is right on lower income communities and lower income countries. So the question is, what is our role? And I think this is something that is, of course, like the Syrian conflict, something that's very important to me. I am Syrian and I grew up in the US, but I used to visit every summer. And I think our role when it comes to these issues, first one is we can always pray. We can always pray that the suffering is eased on those who are struggling, and never kind of put in doubt the power of our thoughts and our prayers. But second, this isn't necessarily a call for me to tell you to care about what's happening in Syria or put more effort into it. I care about what's happening in Syria because it is my country. And I felt a sense of responsibility to give back with the resources that I have. But I think what to me is I think we should all think about what we can contribute to, what communities we can help, and what skills we have that can do that. I had an engineering background, so I was able to help with this project. And I felt it was very fulfilling to do something where I felt like I was actually contributing something meaningful and unique. So I really, it was very inspiring to me after I was finishing this to think about what I can bring to the table. In whatever field that is, in whatever community I'm in, whatever communities we are in, we can always find something that we care about and leverage a skill that we have. Whether we're students or grad students or doctors or professors, there's some skill that we have that we can leverage. And it might be finding ways to help people on a small level, or it might be ways to help people on a larger level. But tapping into that sense of responsibility, inshallah, and finding ways to ultimately, be of service to others. And this was the way that I felt like I could be, and inshallah, continue to be of service to people in my community. Inshallah. Thank you so much for listening. I have my email here at the bottom. And please feel free to reach out anytime. I'm always happy to respond. I might not respond right away, but I will respond, inshallah. And the organization that I worked with in the past is also the website is right there as well. Thank you so much.
Thank you, Abdul Rahman. That was some eye-opening facts for all of us here. Just for the record, we have 340 audiences today who have listened to your presentations. And we are grateful that you have inspiring works that you have done to help our brothers and sisters there in Syria. And it is a highlight for me personally that I like what you said at the last of your presentation. Find something that we love and leverage the skills that we have. I think that would be the highlight for the rest of my life. Thank you, Abdurrahman, for sharing that. So I think we still have 20 minutes from your time of presentations, and I would like to invite questions from the audience. You guys can raise hand from the Zoom and I'll let you talk. Okay, we got one question from Enda Sylvia Putri. Bu Enda.
Okay, thank you, Mr. Firman. The opportunity for me. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Waalaikumsalam
warahmatullahi wabarakatuh.
Assalamualaikum, Mr. Abdul Al-Rahman from Syria, Mr.
Sorry?
Hello, Mr. From Syria.
He's from US.
Yeah,
Yeah,
so
he was
I
born in
grew up.
Syria but grew up in US.
The
Yeah, I
pilot
grew up
project
in the
in
United
Syria.
States. Yeah, but my parents are from Syria, and I used to visit every summer.
Okay. I asked two questions from you. I interest from pilot project in Syria. Very interest. Very empathy for people in Syria. Because they are in conflict and under attack for many years. You know, and as we know. I asked to you, I know the pilot project very high quality because sustainable energy to Syria. Maybe the budget available to pilot project. I think for Indonesia, the pilot project sustainable energy from sun, the budget very high. I think the impact the pilot project maybe low budget to application in the hospital. But the Syria under attack and conflict in Syria. How about hospital and hospital safe to build in the pilot project? I know in Syria under today under attack and the conflict. How about to apply a pilot project? And I think you have the many trouble to build the pilot project. How the minimalist of trouble and build the pilot project in sustainable energy in Syria. The focus infrastructure and the focus hospital in Syria. Maybe my question for you. Assalamualaikum warahmatullahi wabarakatuh.
Salam
Okay,
warahmatullahi
so just to clarify, so
warahmatullahi wabarakatuh.
it's the question is like, how are we approaching, so how are we minimizing risk, and like with the current issues in the conflict, what are
Yeah.
some thoughts on how we can implement projects in the future within Syria?
Yes, I
Yes.
think that is the
Yeah.
question.
So,
Yeah. It's a great question. It's a question that we've thought about, and like, so there's multiple factors. One, the conflict is constantly changing, right? And the regions that are controlled by different entities was for a very long time like always in flux. So sometimes it's controlled by the government, sometimes controlled by a civilian group, sometimes controlled by Daesh, and different entities either allow us to work in them or not. And the part about being a humanitarian organization is that you are supposed to be unbiased, in that when you work in a region, you help everyone, right? But some entities wouldn't give us permission to work in their regions. I think it's still an ongoing problem of like, this was a great implementation of a solar panel project in the region we were working in, but it's a real question of whether that is a good solution within other regions of Syria. And I think we came to the realization that in the current changing circumstances, we couldn't really expand to other locations within Syria for the reasons mentioned in the presentation, which are security issues of things being stolen, as well as risks of things being bombed, and require more oversight required for this, right? So it is engineering, so you need someone who's technically knowledgeable as well to make sure there's maintenance of this project. However, we kind of have just like shifted gears, right? So solar energy is one aspect of sustainable energy, and there's other ways to leverage technology. So we've switched to more looking at how we can use, and right now in the era of COVID, like telehealth is becoming really important, right? So, and I think the lesson I learned from that was I was very excited about the solar panel project. And I thought, oh, if we could like expand this and think about it in other locations. And it was very hard to come to the realization that maybe it wasn't the best solution for other regions. And I think the lesson I learned was it's really important to be able to pivot when you realize that the solution you're thinking about doesn't work for the problem at hand. It's not solving an issue, or it might not be the most effective solution. And I think that's really hard in academia in general, and in any field we're in, is like you invest a lot of time on a certain goal, and then when you see it, you can't take it in that direction. It's really hard to give up on it. But sometimes you have to accept that there's like it wasn't sunken costs, right? Like we learned a lot of lessons. We were able to benefit one hospital, but we then shifted our focus to something else, which right now we're like telehealth. We do a lot of like radiological imaging. When we have like scans, like x-rays and CTs at hospitals, CT scans at the big hospital and like x-rays at portable x-rays at smaller hospitals, we have radiologists who are like virtually reading them, who are present in Turkey or in the United States, who are like not even, they'll get a notification that there's a new report. We're doing the training, like I mentioned. So it's something that we're starting to think more about in the region, in the context of the conflict in terms of telehealth.
okay, thank you.
Thank you, Abdurrahman. While waiting for others questioners, I have one question for you. And how did you fund the project? Like, how did you get support financially?
We actually, there was the German kind of like USAID, which is the US nonprofit arm. US government, like there's like I don't know what USAID actually stands for, but it's like a nonprofit arm that's part of like the larger governmental structure within the United States. Germany also has a very similar structure where they have GIZ. It's like a German nonprofit structure. So they helped fund the project a lot for us. And we also got some like private funding from it, but mostly it was actually by help from a German nonprofit arm within Germany, which was, very, very nice to have like the direct funding from not just like local and private sponsors.
Thank you. We got one more questioner. from Ibu Sukma Elida. Ibu Sukma.
Yeah, can you hear me?
Yes, go ahead.
Okay. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum.
Thank you for the opportunity, Mr. Firman. Good morning, Mr. Abdul Arrahman. Good to see you. I'm sorry to hear that to hear what happened in Syria, and I give you highly appreciation for what you have done in Syria. Maybe you can tell me what about the maintenance of the solar source of energy?
Yeah, so in terms of maintenance
Yeah,
of the
that's
panels,
all.
like what
Thank
we
you.
had to do to maintain, to make sure they were working. Okay. So there is we had, for the first like couple months, we had an engineer on site who was present all the time to troubleshoot. But afterward, because we were right across the border, we actually had someone that was kind of present on call who would come if there's any issues that were happening. And we also had, there's always like maintenance checks. So like within the system, every day, you know, it's running its own self checks and making sure everything's working and that like the power supply lines are working. But we did have like funds set aside for someone who is responsible for maintenance. The nice thing about solar panels is they're actually much lower maintenance than you would expect. They're very sturdy. They're very resilient. And like the casing's done really well. And like, you know, here, I don't know how it's like in with you guys, but with us here in the United States, there is starting like a lot of private homes, you know, people who have the wealth to be able to do it, but they're getting solar panels on their homes. And sometimes they can go years without any issues. Our setup was a little bit more expensive, so it did require more maintenance, but alhamdulillah, like that was within the funding that we had within our grant, was to pay someone to maintain the panels when they needed to. And we also had to pay for we just kind of increased the level of security just a little bit at the hospital to make sure things wouldn't get stolen.
Okay, thank you. One more question. What about the price if before and after solar energy implementing in the hospital? The price of the maintenance.
Okay.
Before
cost?
we still, yeah,
Okay.
yeah, the cost.
I don't have those numbers available right now.
Oh.
I would have to like do a little bit of digging. I'm sorry, I didn't pull them up. But I do know, like on average, once we, so I showed some results from the pilot project, but once we got the, once consistently while we were running, on average, we were saving, in terms of savings, this is factoring in the cost of maintenance, factoring in the cost of like anything ongoing with the panels, we were still saving about like $7,500 per month. And it varied on average. So during the hotter months and the months with longer days, it was more, and with the winter days, it was less.
Okay, thank
All
you.
right. Thank you. Any other questions from the audience? Abdurrahman, with the COVID-19 pandemic going on around the globe now, do you have any idea how is it going on there in Syria? I bet it will be a double burdens or maybe triple
Yeah,
for
it's
them, but do you know yeah.
No, sorry for cutting you off for a minute. It's hard to tell. So there's not much reporting going on in Syria, right? There's not a lot of testing happening. And there was a recent report from a London agency, like a research group, that was looking at reporting of COVID-related deaths in Syria, and was estimating that only between 1% to 2% were being reported, for a factor of reasons. One is being government not reporting anything, like hiding reporting. Two, lack of testing. So we don't know why people are dying. Some people are dying, but like we wouldn't know if it's because of COVID. We're not being tested. And three, there's just there's a lot of people who we don't hear about, right? Like there's no news reports about them. They live in areas that aren't connected to anyone. And this research study was very, of course, rudimentary. Like it's really hard to how did they come up with that number? But they were trying to kind of they collected they like looked at communities and they would like look at like WhatsApp, like reach into like people in that area with WhatsApp, figure out how many people died over a course of a week, look at local obituary reports, just try to get more information from locals about certain cities, and then based on like death rates in that area and compare it to official death rates. It's very, of course, not very accurate. But basically, I think the summary is like, we really don't know. It's really hard to tell what's going on because there's not as much reporting. But I do think there's a general trend that we've seen is that we're still trying to understand this virus because a lot of places that we would have thought got hit really hard, like refugee camps and like really high density areas that would have just gotten wiped out, haven't been hit as hard as we would expect. We don't know if it's because of certain ethnicities, certain regions, and then like places here like the United States where people are taking precautions. The government hasn't done the best job of isolating people, but it's just certain locations have been harder than others, and it's hard to understand why exactly the factors are.
All right, thank you so much, Abdurrahman. If there's no more other questions, I think we can move on to the next speaker. Thank you again. The next speaker will be Dr. Moi Fong Ming. She is a professor from the Department of Social and Preventive Medicine, Faculty of Medicine, University of Malaya, Kuala Lumpur, Malaysia. And she got her PhD from the University of Malaya in 2007, and then MMed in Public Health from the University of Malaya in 2001, and Master of Science on Nutrition from National University of Malaya in 2001, and also Bachelor in Honors in Dietetic from National University of Malaysia. And she has published a number of research and won some grants to conduct research, including development and testing the usability and effectiveness of a mobile diet app, and then a study on a social and cultural acceptability of sustainable diets among Malaysians, and a study on the public health, genomic, environment, and the knowledge awareness among health professionals, university students, policymakers, and the general public in Malaysia, and clustering of lifestyle risk factors and understanding its association with stress on health and well-being among school teachers in Malaysia, and a spatio-temporal modeling and meta-analysis. And her postgraduate teachings, including epidemiology of non-communicable diseases, and then clinical epidemiology, essential epidemiology, advanced research methodology, nutritional epidemiology, principles and method of epidemiology, and research project and research methodology. Without further ado, let's invite Professor Moi Fong Ming. Dr. Moi, can you hear me?
Yes, thank you, Dr. Firman, for the kind introduction. First, I would like to thank the organizing committee for inviting me to share a review on my topic, that is malnutrition, double burden of malnutrition and COVID-19. I would very much like to visit the university, but unfortunately during this COVID pandemic, we have to do it virtually. I would like to congratulate the Faculty of Public Health in organizing this second International Conference of Public Health. Well done. Okay, now I would like to share my screen. Can you see my screen?
Yes, it's the cover page.
All right. Yes. All right. So as introduced by Dr. Firman, I come from the Department of Social and Preventive Medicine, which is equivalent to public health. And I'm from the University of Malaya, which is in Kuala Lumpur, the capital of Malaysia. Actually, we are very near. So welcome. We welcome you if when we are allowed to travel. Okay. So the outline of my talk would be, first, we will talk about double burden of malnutrition, global targets of nutrition and the SDGs, and how much have we achieved, and a brief introduction on the current situation of COVID, as well as the consequences of COVID-19 control and mitigation measures on nutrition, and finally, a brief discussion on measures to combat malnutrition during the COVID-19. Right. So what is double burden of malnutrition? I'm sure most participants would know that double burden of malnutrition involves undernutrition and overnutrition. So the undernutrition that I'm going to talk about would be wasting, stunting, along with overweight and obesity. Because of time, I'm not covering the micronutrient deficiencies. Okay. With overweight and obesity, we also have the diet-related NCDs. So this double burden of malnutrition can happen among individuals in the household or populations over the lifespan. Okay, so I'm not going to go through this. So why do we want to study malnutrition? Because as we all know, malnutrition is essential to achieve the SDG. All right. Nutrition is also critical to health and economic development. If we don't have a healthy population, we don't have healthy workforce. So the economy of the country will be affected. In addition, also it is good to promote maternal, infant and child health, because healthy babies will give us healthy adults and so on. And healthy children, teenagers will have good school and education performance, and will have stronger immune systems and reduced risk of diseases. I'm going to use the latest joint malnutrition estimates by UNICEF, WHO, and the World Bank Group. So according to the report, there are 144 million under 5 children who are stunting, which is equivalent to 21.3% globally in 2019, with 47 million children wasting, which is equivalent to 6.9%. As on the other hand, we have the overweight children, which is 38 million, or estimated 5.6%. So for the 5 to 9 years old children, we have 131 million who are overweight and obese, and 207 million adolescents who are overweight and obese, and 2,000 million adults who are overweight and obese. So we can see that we have the undernutrition as well as overnutrition on the other hand. Right. Here we would like to take a look at the trend from 2000 to 2019 for the percentage of stunted, overweight, and wasted. So this purple line refers to the overweight. So from year 2000, the global prevalence was 4.9, and after almost 20 years, it went up to 5.6%. Whereas the stunting, from 32.4%, it has come down to 21.3%. Although it has improved, but it is still not good enough. As for the wasted children, there's no data for global data for 2000 up to 2019. So this only presented as 6.9% in 2019. So this chart show the numbers. So it was from 199 or 200 million who were stunted. Now it has reduced to 144 million. So for overweight obese, it's from 30.3%, it's gone up to 38.3%. So which continent has the greatest share of all forms of malnutrition? From this report, it is reported that Asia and Africa bear the greatest share of all forms of malnutrition. So for the stunting children, Asia contribute. There are 54% of Asian children are stunted, with 40% from Africa. Wasted children, 69% come from Asia, and 27% from Africa. And the overweight children under 5, 45% come from Asia, and 24% come from Africa. So we can see that there is over and undernutrition happening at the same time. That's what we mean by double burden of malnutrition, right? So we also can take a look at the statistics in each region. So in average, Southeast Asia has a prevalence of 24.7% of stunting, okay, compared to 2.6% in Northern America, all right? So we can see that Africa also is quite high, around 30%. Southern Asia also 30%, 31.7%, and so on. There's no data for Australia and New Zealand. Right. So we also would like to take a look at the trends in the percentages of stunted children under 5 from 2000 to 2019. So just now we have gone through the overall global prevalence was from 32.4% to 21.3%. So for Asia, which is where we are, it was from 37.8% in year 2000, and now it is 21.8%. But if we look at Southeastern Asia, we are slightly higher than the average. So currently we are at 24.7%. Okay. If we compare to Africa, it's in the 30s and 40s in year 2000, and then now it is around, the lowest is 17.6 in Northern Africa. All right. If we look at the America, Central America, South America, and then they are doing better. So although the improvement is not as what we would like to, but we have improved from, so for the Southeast Asia is 38.5% to 24.7%, right? So for wasting, for our region, it is about 8.2%, where the global prevalence is 6.9%. So we are still a little bit higher than the global prevalence. Compared to Southern Asia, which is 14%, and yeah, if you compare to Northern and Central America, which is less than 1%. So, so this is another way of showing the percentage. So percentage of wasted children under 5, it is about 1 in 10 in Asia and Oceania. Right. On the other hand, when we have undernutrition happening, we also have the overnutrition. So the percentage of overweight children under 5, we can see that in our region is about 7.5%. Australia and New Zealand is about 20.7%. And Africa, it is, Southern Africa is 12.7%. Southern Asia, with very high undernutrition prevalence, the overnutrition is 2.5%. All right. So globally, the prevalence of overweight has increased from 4.9% to 5.6% over 20 years. Okay, so if you look at Asia, it has increased from 4 to 4.8%. For Southeast Asia, from 3.2%, it has gone up to 7.5%. Okay, so right, this is that means besides the undernutrition, we also have the overnutrition that is happening together. We can also take a look at the percentage by income classification. So we can see that for the low income countries, the percentage of stunting has come down. Similar for lower middle income as well as upper middle income. But for the overweight category, for low income, it has come down a little bit, but for lower middle income, it's gone up a little bit. So for upper middle income, it has gone up a bit more. So if we compare the lower middle income with the upper middle income, we can see that the rates is double in the upper middle income compared to the lower middle income. Okay. Right. So having known the current situation of malnutrition, the WHO has come out with the global nutrition targets, which has to be targeted to be achieved in 2025. So to have a 40% reduction in the number of children under 5 who are stunted. So at the from baseline 2012, which is 160 million, the target should be 100 million by 2025. 50% reduction of anemia in women of reproductive age, 30% reduction in low birth weight. So because of time, I don't cover these two sections. Okay, so for childhood overweight, the target is no increase. So if it's baseline at 7%, it should be maintained at 7% by 2025. Okay, and finally, the wastage, reduce and maintain childhood wasting to less than 5%. So at baseline 2022, it was 8%, and in 2025, it should be less than 5%. So these are the targets set. Okay. In addition to that, the nutrition also contribute to NCDs. Okay. So NCDs such as cardiovascular disease, chronic respiratory diseases, cancers, and diabetes. So NCDs are responsible for 71% of all deaths worldwide, which is equivalent to 41 million people. And 15 million people die from NCD between the ages of 30 and 69. And over 85% of these premature deaths occur in low and middle income countries. And these 4 groups of diseases accounted for over 80% of all premature NCD deaths. So you can see that the death from CVD is the highest with 17.9%, followed by cancer, 9%, coronary respiratory diseases, 3.9%, and diabetes, 1.6 million, sorry, it's million, 3.69 million and 1.6 million. So there are also measures to address NCDs, diet-related NCDs. So we've come out with the risk factors, and what we also the globally modifiable risk factors, which are from tobacco contributed to 7.2 million deaths per year. And excessive salt or sodium intake contributed to 4.1 million annual deaths. Alcohol use, more than half of the 3.3 million annual deaths. And sedentary lifestyle or insufficient physical activity contributed to 1.6 million deaths annually. For the metabolic risk factor, raised blood pressure contributed to 19% of global death. And other factors which are related to metabolic are overweight, obesity, hyperglycemia, and hyperlipidemia. So there is also global targets for NCD. So these are the targets that it should have a 25% relative reduction in risk of premature mortality from CVD, cancer, diabetes, or chronic respiratory disease. At least 10% relative reduction in the harmful use of alcohol, 10% relative reduction in the prevalence of insufficient physical activity, 30% reduction in population intake of salt and sodium, a 30% relative reduction in prevalence of current tobacco use, and then 25% relative reduction in the prevalence of raised blood pressure. Halt the rise in diabetes and obesity. At least 50% of eligible people receive drug therapy and counseling to prevent heart attack and strokes. And 80% availability of affordable basic technology and essential medicine, and so on, to treat major NCD in both public and private facilities. So these are the targets set for to address the problems of NCD. And we also have the latest, that is the Sustainable Development Goals, which goal number 3 on good health and well-being is more of interest to us, is to ensure healthy lives and promote well-being for all at all ages. So some of the targets are to reduce the global maternal mortality ratio to less than 70 per 100,000 live birth, and preventable death of newborn and children under 5, reduce neonatal mortality to at least as low as 12 per 1,000 live birth, and under 5 mortality to at least as low as 25 per 1,000 live birth, and to end the epidemics of infectious diseases such as AIDS, tuberculosis, malaria, and so on. And then to reduce by 1/3 premature mortality from NCD, as well as strengthen the prevention and treatment of substance abuse and so on. So I'm not going to go through the rest. Right. So having set all the targets, there is a 2020 Global Nutrition Report, which found that we are not reaching the targets. We don't seem to be able to reach the target by 2025, as for example, for childhood stunting. So at baseline, the number of childhood stunting was 165.8 million. But in 2018, it was still 149 million. And the target we need to achieve, 40% reduction, is around 100 million. So we are not progressing as we should if we want to achieve 40% reduction, right? Similarly, for childhood wasting, in baseline 2012, it was 7.9%. And in 2018, we are still 7.3%. So by 2025, we need to achieve 5%. So looks like also it is difficult to achieve the target. Same for overweight, childhood overweight. We were 5.5%, but 2018, it was increased to 5.9. The target is no increase. So we should be 5.5% or less. So despite having the targets, we know that we are off course globally. For diet-related NCD targets, we target to have 30% relative reduction in mean population intake of salt. In baseline, the population intake of salt was 5.6 grams per day. But in 2017, we were still consuming 5.6 grams. Okay, if you break down into men and women, the men has an intake of 5.8 grams and women 5.3 grams. So 30% relative reduction means that we need to achieve at least 3.95 gram or around 4 gram. So again, we are off course. Raised blood pressure. So in baseline 2014, percentage of having a raised blood pressure was 24.3%. 2015 is still 24.1%. The target is to reduce 25% relative reduction, which is 18.2%. So so this is for men. For women, the baseline was 20.2%. In 2015, we were at 20.1. So we need to achieve 15.2. So look like we are not meeting the global nutrition targets in salt and blood pressure as well. Right, so next is we look at the adult obesity target. Baseline, so the target is stop the rise. That means no more increase. In baseline, it was 10.4% among men. In 2016, it increased to 11.1%. Target is to maintain at 10.4% for men. For women, at baseline, it was 14.4%, but 2016, it was 15.1%. So this shows we failed as well. Adult diabetes, stop the rise in prevalence of diabetes. In baseline, among men is 8.7%, but in 2014 data is 9%. So target, okay, we target at 9% rather than 8.7%. Okay, so for women, 7.7%, and 2014 is 7.9%. So now we are actually not stopping the rise in prevalence, but we are increasing. Okay, so in terms of global nutrition targets, we fail in all the targets that we set. How about the SDG? Okay, so this is the SDG scorecard for just Southeast Asia. So for target number 3 is good health and well-being. So this is a target that we need to achieve. In 2019, we are not even reaching what we should. Okay, so some regress, like peace, justice, and strong institution. But from looking at the global nutrition targets as well as the SDG 3, we are not doing well. Okay, that was before the COVID-19. So with this COVID-19 pandemic, it has swept the world. And as of 28 October, we can see that the situation by WHO region, the America has the worst situation, followed by Europe, and Southeast Asia, we hope to be improving. Okay, and Africa is doing quite well. So these are the confirmed cases. As for death, we can see that initially the Europe region has quite a lot of death, but now it has come down and kind of plateau. But recently, in the month of October, it has having a increasing trend. But if you see the Americas, it is still very. You can see that the situation is still very aggressive. For Southeast Asia, we are not improving. Okay, and this is just to show what's happening in Malaysia. In Malaysia now, we are having a third wave with the epicenter from Sabah, and Sabah contributed the most cases, 14,000 cases, and the number of deaths is 249. Currently, the Klang Valley, Selangor, and Sabah are under the conditional movement control order. So that's Kuala Lumpur is where I am. Here it is here Kuala Lumpur, Selangor, and there is under CMCO as well as Sabah. Okay, so we are, as I mentioned just now, we are having a third wave. So we have been doing quite well last 2 months, but in September, October, it has shot up. So this is the current situation in Malaysia. All right, so before COVID, we failed in all the targets. So what do you think will happen when COVID is here? With all the measures to contain and control the disease. All right. So what are the containment and mitigation measures conducted by Southeast Asia countries? So we can see that mass testing, contact tracing. Okay, so the most frequently taken measures are border closure, screening at port, travel bans, social distancing, school and university closure, and closure of public places. These are the common measures taken by countries in Southeast Asia. Some punishment on violation of isolation orders, as well as lockdown, declared lockdown, declared state of emergency, and contact tracing. Okay, right. So all these measures like travel ban, border closure, social distancing, school, university closure, and closure of public places, lockdown, all has consequences on the population. Okay, especially these aspects: nutrition and food security, economy, medical, and health. So what are the consequences on nutrition and food insecurity? So because of closing of border and so on, there's global demand for agri-food products, as well as disruption of local food markets because of the lockdown. Food products, agriculture products cannot be sent out to the urban areas, a lot of food wastage, and because of the food cannot reach the urban areas, and prices of food increases, as well as for those vulnerable groups who are in poverty, they have loss of income because of the lockdown, or so they cannot work, they lost jobs, and so they cannot access, they have difficulty accessing food. And because of the lockdown or movement control order, or prices of more nutritious food to be higher, so there's difficulty to access nutritious and nutritious food. So due to school closure, those vulnerable groups which are in the poverty, they actually are missing out meals at the school. Okay, so we can see that 368 million of school children, which 48% are girls, are missing out on meals. Okay, so yeah, so those who are on school meals, they actually lose the opportunity of having nutritious meal that is provided by the school or government. Okay, so in terms of economy, the country GDPs are affected because of diminished sales and losses of perishable stock due to movement control or lockdown. Some farmers have to destroy their products and so on. And due to the closure of factories and shops, the production capacity is reduced, market access is limited, and then affect the merchandise trade of certain countries like Singapore, Malaysia, which deal with this. And Countries that depend on tourism will have loss of income because of border closure. And all this contributed to loss of jobs, lack of employment opportunities, and loss of remittance. Migrant workers who work in other countries, they would lose their job, and they will the remittance sent back to the countries will be reduced. So if you see that there are countries which depend quite heavily on their migrant workers, like Philippines, Indonesia, Myanmar, Vietnam. And the World Bank projected that the migrant remittance back to their own countries could decline by 13% because of the loss of employment, jobs, and so on. All right. The forecast of employment rate, it is also done. As you see that unemployment rate in these three countries before COVID was 5%. Indonesia was 5%. Now it's forecast to be more than 7%. In Malaysia was around 3.5. Now it's 4.5. And in Philippines is 5%. And now it is up to about 6%. So with all this, the COVID impact of the GDP growth for Southeast Asia, for Indonesia, the forecast, the earlier forecast, the GDP growth was about 5%. But after COVID, it is still a positive growth at 2%. But if you look at Malaysia, from 4%, it become a negative. So there's no growth. So countries that has negative GDP growth are Singapore, Thailand, and Brunei. Okay. So this is the impact of COVID-19 on the GDP growth forecast. Right. So the last consequence that I'm going to talk about of COVID is on medical and health. As we all know that we have a group of undernourished children, and they are also come from the more vulnerable group, which is they are in poverty. So due to the loss of income, loss of jobs from the family members, the parents, so they may be exposed to hunger and malnutrition, and this will weaken their immunity and so on. All right. So for the children, for the whole family as well. So for the those who are obese, okay, the adults who are obese or with NCD, they were found to have worse COVID-19 outcomes. They have increased risk of hospitalization and death if they were infected with COVID. In addition, due to the pandemic, there is disrupted clinical service. So where it influence on the maternal and child health, like vaccination programs need to be halted, but maybe now it has started back again. And there may be some children who miss immunization, and mothers who are pregnant may have to have a home delivery and so on. Okay, so for non-communicable disease, services are also disrupted or halted for some reasons. Okay, so this is the from the impact of COVID on NCD resources and services. We can see that all the NCD services are actually disrupted, either partially disrupted or completely disrupted. Okay, and we also found that in Netherlands, the number of people newly diagnosed with cancer dropped by 25% as a result of the lockdown. It's not because less people get cancer is because of there is no screening, and also it become unknown. There's a drop. Okay, so from the survey also is found that the more severe the COVID situation, the more NCD services are disrupted. So if it's, yeah, so you can see that. Okay. So the main causes of NCD service disruption are actually elective care were cancelled, probably to avoid transmission between patients, and population level screening programs also closed, as well as transport, government or public transport were stopped. So it prevent the access to health facilities. And another reason was that NCD related clinical staff were deployed to provide COVID services. Closure of outpatient disease-specific consultation clinics were another reason. Insufficient PPE for healthcare providers to provide services. Insufficient staff to provide services, and closure of outpatient NCD services as per government directive. Actually, from my faculty, my faculty has a university during in March, from March to June, we actually have stopped all other services except COVID. But now we have resumed the the full spectrum of services. All right. So also some reasons are that patients, they're scared, they don't go to the hospitals. Okay, for the service. Another reason for service disruption. So in the survey, the countries were also surveyed on whether they have given additional funding to include NCD services in the national COVID plan. So we can see that most of the countries actually have around 12 to 20% of funding to include NCD service to build back better. Okay. Right. So finally, what should we do to combat malnutrition during the COVID-19 pandemic? So for food insecurity, probably we should not depend so much on food import. So it should promote more local food production and consumption. And nutrition resilience is important because good nutrition is essential for an individual's defense against COVID. So there should be synergies between public health and equity in line with the 2030 agenda for SDG, and to continue NCD services in the national COVID-19 plans. So we can see that it is multi-sectorial in the food environment, food supply chain, consumer behavior, and the impact on social, economic, and environment, as well as policy, program, and institutional action. Okay, so finally, even though we are not doing well in the SDG, we should move forward, and we should have the strategy that include NCD to build back better to reach SDG 3.4 on NCDs. I think this is the last slide, and thank you. This is a picture of my university, and you're welcome to visit us when the borders are open. Thank you.
Thank you, Dr. Moy. That was a wonderful statistics that we got from, especially in Asian context, yeah, which is very timely and relevant for all of us in this situation. I see here in the audience there is the representative of the Association of Indonesian Nutrition Experts, or Persagi Pangan Indonesia. And there is also the health office of Aceh Barat, Dinkes Aceh Barat ya, sudah bergabung. Thank you for joining us today. We still have time for question and answer for Dr. Moy. And I see from the audience, there are two people have already raised their hands. Dr. Moy, the first one
Yes.
is Yolanda. Yolanda, can you hear me?
Yes.
Yeah, go ahead, Yolanda.
Okay. Thanks to moderator who has invited me to submit my question. And thanks also to Prof. Moy, because your explanation is very interesting. And I see in your slide, your present, there is a association with malnutrition with COVID-19. And so, how much is malnutrition related to COVID-19? And then, from the slide you're present, why is stunting higher in Asia than Africa? And then, how big is estimate success on global nutrition target by 2025? Thank you.
Okay, thank you, Yolanda. You actually have three questions, right?
Right,
The
yeah.
same question.
Yes,
She got
So the
three.
first question is, how is malnutrition influence COVID, right?
Yes,
So yeah, so malnutrition, if we talk about obesity, that is overnutrition, if we check the hospital data, people who are obese, actually they have poorer outcomes when they commit COVID. It's not that obese people are more easier to get infected, no. But once they have got infected, they have poorer outcomes, like they need the ventilator more, or they need to be admitted into ICU. So it could be because they are inflammation. It is like people who are obese are also more at higher risk for NCDs. Similar, the people with NCDs also would do worse in when they have COVID. All right. So for the undernutrition, the undernourished people, because of their immune system are poorer, so they also have they could have higher risk of getting infection. However, we don't have evidence on that, but that is from the understanding of other diseases, so that is what it is expected. Okay. What is the second question? So the second question is, sorry, I forgot what is the second question.
And how big estimate success on global nutrition target by 2025?
Okay, so from the slides that I showed, the 2020 nutrition report, we are not achieving actually all the goals. Okay, so for stunting, we should reduce by 40%. But in 2018, we are still far away from the 40%. Because at baseline for stunting, globally, there were 165 million. But in 2018, there was still 149. And the target is 100 million. So it is obviously that we cannot improve on almost 50 million of children. So for wasting, it was supposed to be at baseline was 7.9%. In 2018, it was only 7.3%. So the target is to be less than 5%. Again, it is estimated that we cannot achieve. For overweight, childhood overweight, at baseline, it was 5.5%. But in 2018, it was 5.9%. The target is no increase. So now we have to work on reducing the 0.4%, which is also a bit of challenging. So these are for the over and under nutrition. Similarly, for salt and raised blood pressure. So for salt, it was baseline was about 5.6 gram, but in 2017, it was still at 5.6 gram, which the target is 3.95 gram. So that's why from this 2020 Global Nutrition Report, it is estimated that it is challenging to achieve the target.
Thank you, Dr. Moy. The third question
Okay,
was...
thank you.
Actually, Yolanda has the third question.
Yeah,
the
I
third
forgot what's the
question
third
was,
question.
Yes, the third question was why stunting in Asia is higher than in Africa.
Why is stunting? Okay, yeah, that is global data.
Right.
Actually, you think Asia would do better than Asia would do better than Africa?
Than Africa. Yeah.
Okay, so actually in Africa, actually in average, if you look at no, actually you cannot see, I didn't share the screen, but from the data, stunting, in Africa, it was 29.1%, but in Asia is 21.8%.
So it's lower in Asia than in Africa then?
Yeah, yeah.
Okay.
Oh.
All right. But actually,
but Africa's
yeah, it's different way of seeing it. It's different way of seeing it. Yeah.
Okay. All right then. Thank you, Dr. Moy. The next question from Tria Ningsi. Tria, can you hear me?
Iya, Pak.
Yes, yeah, go ahead.
Pak, tapi sebelumnya nanti jawabannya tolong diterjemahin ya, Pak.
Okay.
Okay, hello, Mrs. Moy.
Hi.
Okay, I'm Training C, a student from the Faculty of Tengku Umar. I'm Training C. I'm a student from the Faculty of Public Health from University of Tengku Umar. My question is, how is the action of the Malaysian government to solve this problem, stunting?
Actually, it is through the school meal, as well as the food basket. So for those children who are on a vaccination schedule, those infant to 1 year old, they have they would go back to the clinic for vaccination. So that's where they can provide food basket. The food basket is actually for the family, which we felt that it is not very not perfect, because it's the child that is stunted, but the whole family get food. But they do have a milk powder there, and they have some like rice, noodles, dried noodles, and so on. So it depends. So for those who are going for vaccination, they will get food basket. For those who I think under 5 they give food basket. For those going to primary school, we give a school meal. So that's why, because of the closure of school, these children miss out nutritious meal from the school.
Okay.
Yeah.
She asked me to yes, so she asked me to help translating your answer, so I'll do that. Jadi
Okay.
Tria, programnya
Iya, Pak.
itu ada 2 dari pemerintah Malaysia. Yang pertama adalah program school meal ya, makanan di sekolah, dan program food basket, makanan keranjang. Jadi kalau anak-anak di bawah 5 tahun, dia pergi imunisasi, dia dapat food basket itu. Sedangkan anak-anak yang di atas 5 tahun, yang pergi sekolah SD, gitu, mereka dapat school meal. Nah, makanya ketika COVID ini terjadi, kemudian sekolah-sekolah tutup, imunisasi juga tutup, makanya anak-anak ini tidak mendapatkan tambahan nutrisi makanan pemerintah itu. Gitu.
Okay. Thank you, Mrs. Moy. Nice to meet you.
Yeah.
Thank you. Any other questions from Ibu Dian Vera? Bu Dian. Another question from Ibu
Thank
Dian.
you, Mr. Firman. Good morning, Mrs. Moy. My name is Dian Vera. I am lecturer of Faculty of Public Health, Teguh Umar University. The death rate due to children in Indonesia is high. While Malaysia, Vietnam, and Singapore released 0 case of children who died in the world due to COVID-19. Why can there? And how is the program for the management of COVID-19 in the country of Malaysia, Vietnam, and Singapore? Thank you.
Did you get the question, Dr. Moy?
Can you repeat? I don't get the question.
Ya, Bu Dian bisa diulangi pertanyaannya. Mungkin nanti saya bisa bantu terjemahkan.
Oh ya. Pertanyaannya, Pak, tingkat kematian COVID-19 pada anak di Indonesia tinggi, sedangkan di Malaysia, Vietnam, dan di Singapura tercatat 0 kasus anak yang meninggal akibat COVID-19. Mengapa bisa demikian? Dan bagaimana program penanggulangan COVID-19 di negara Malaysia?
Okay. So the question is, Dr. Moy, the question is death cases
Bingung
of
itunya.
death cases in Indonesia for children affected by COVID-19 is higher comparing to those in Malaysia, Vietnam, and Singapore. So the data said that there is 0 confirmed cases or death cases for children in Malaysia, Singapore, and Vietnam. And do you have any idea why is that that's happening, and what's the program or the preventive or the actions taken by the government to manage that cases?
Okay, yeah, understand. Thank you. Yeah, actually in Malaysia, there are very, very low number of children death due to COVID. I think recently there were 1 or 2 new 1-year-old child died of COVID. I think it's because of the steps taken by the government, where first the government admit all COVID cases. Once you are positive for COVID, you are admitted. So not like some other countries, if you are symptom free, you can be you can go home, and then you try to recover at home. But in our country, we admit all patients, whether you are with symptom or without symptom. So I think that is one of very important step that reduce the transmission from the patient to the family members who are not only adults but elderly and children. So that is one reason. Another reason is that schools are closed, nurseries are closed, the children have to stay home. So that is why probably the transmission is low. Yeah. I think the main reason is that all patients, as long as you're diagnosed, you need to be in the hospital or in the COVID center for treatment. So that will stop reduce the transmission. And also the government has also like tell the elderly and the children not to come out to crowded places and so on. I think that is
Alright.
one of the main reason. Yeah.
Okay. Thank you, Dr. Moy. I
Thank
think it's 11 now, and I think that's a good stopping point for Dr. Moy presentation. Actually, as I said earlier in the beginning of this conference, that we have another keynote speaker named Professor Paul Ward, but unfortunately, he is unable to join us today. He's from Australia. There's some things going on, unforeseen circumstances, and which is unfortunate, but never mind. We already listened to 3 speakers for today's agenda, which is from Bangladesh to Syria and into Asia. And I think it's conclude our conference today about the multidisciplinary research on public health and medicines in pursuit of SDGs and in response to COVID-19 pandemic. Dr. Haider and Abdul Rahman have left out the Zoom because in the US it's now past midnight already. So yeah, it's past midnight in the US. So they have left, and it's unfortunate that the Zoom meeting, we have time difference in this Zoom meeting, but it's okay. I would like to thank you again to all of the speakers who have shared and presented their paper. And I believe that the insight, the arguments, the data, the inspirations that you have shared would be beneficial and shed light on the topic, on the theme of the conference of today's agenda. And I think that would be all for today. Thank you again. And we will have a second session, which is a parallel session or plenary presentation starting at 2 p.m. Yeah, 2 p.m. Today. Let me share this. Okay. So for those of you who are presented, who will be presented your paper or presenters, please rename. When you log in back to this link, you can rename your Zoom just like this, presenter and then underscore and then what room you will be and then your full name. Dan untuk semua partisipan ya, untuk semua peserta yang mau gabung di sesi siang nanti pukul 2, itu bisa lihat kira-kira mau bergabung di ruang yang mana. Nah, ruang yang mana itu ruangnya bisa dilihat di link ini ya, Abstract Book Icph 2020. Dilihat presenternya siapa, ruang apa. Kemudian nanti ketika masuk kembali ke Zoom, namanya diganti dengan partisipan. Kemudian ruang apa yang mau masuk. Kalau mau masuk ke ruang A, buat A. Kalau mau masuk ke ruang E, ruang D, maka buat ruangnya di sini. Dan baru nama lengkapnya. Sehingga memudahkan host nanti merename, memasukkan kalian ke dalam ruang-ruang tersebut. Gitu saja. And bisa join kembali nanti pada link Zoom yang sama ya. Pada link Zoom yang sama yang sudah dibagikan tadi. Kita mulai acara jam 2, jadi kalau bisa sudah bergabung di 1.30 atau 1.45 paling telat. Sehingga memudahkan host untuk memasukkan ke ruang-ruang yang sudah ditetapkan. And Dr. Moy, thank you again for your participation and attendance. We appreciate that. And we will send you a token of appreciation later via email. And Bapak Ibu, thank you so much for your participation and patience during this agenda and event. And I would like to end for this session by saying Alhamdulillah. Assalamualaikum warahmatullahi wabarakatuh.
Wabarakatuh.
And if you don't mind guys, we can take a picture together. Ya, kita akan foto bersama. Saya lihat ada 14 slide di sini. Host mungkin bisa bantu. Berarti kita akan foto 14 kali ya. Foto yang pertama 1, 2, 3. Yang kedua 1, 2, 3. Yang ketiga 1, 2, 3. Slide keempat 1, 2, 3. Kelima 1, 2, 3. Keenam 1, 2, 3. Ketujuh 1, 2, 3. Kedelapan 1, 2, 3. Kesembilan 1, 2, 3. Kesepuluh 1, 2, 3. Kesebelas 1, 2, 3. Ke-12 1, 2, 3. Ke-13 1, 2, 3. Dan yang terakhir 1, 2, 3. Baik, terima kasih. Bapak Ibu sekali lagi bisa bergabung nanti kembali ya. Semua peserta dan presenter dapat kembali pukul 1 atau kalau tidak mau meninggalkan Zoom juga bisa standby Zoom-nya tetap nyala. Tidak masalah. Nanti bergabung lagi dan menggunakan nama sesuai di layar yang sudah saya tampilkan ini. Terima kasih. Selamat menikmati makan siang dan istirahatnya. Hah? Dari abang? Dengar ya? Nggak dengar.
I want to tell you the best journey of my life.
Now I'm in Rangit Kachil, this beautiful, amazing island. Just look around me. Amazing, beautiful. I'm so happy to come here. And beside me, I have this amazing lighthouse. One of the most beautiful things I've ever seen.
This is the first woman I loved.
I love this place. So many palm trees.
She's the one who introduced me to this place, to let me find an answer. I think this is the time to let the adventure begin.
Hey, penutupan Anda.
Excuse me, you know where is this place?
You can come with us, tapi kamu harus lanjut lagi pakai kapal.
Can I join you?
Oke.
Okay, thank you.
I met good people along the way. Their kindness really moved me.
Bang Manap, ini ada kebetulan ini mau ke pulau. Tolong diantarlah.
Hello. Hi, nice to meet you. Matt. Come on, buddy. Goodbye. See you.
Along the journey, I can see why my mom was so in love with this place. My whole sense awakened by this incredible nature. And the people who are sincere can be seen and felt.
Ikan. Good.
I learned that behind every graceful movement of this dance has a special meaning. I've had the best shower of my life. Explored the most tranquil forest that make me hear my own heartbeat. Every single thing of this place make my heart tied up with love. Just like what it did to her.
What will you do when I leave?
I gonna miss you. This is for you. Dipakai ya, jangan hilang.
I love it. Terima kasih. She's like the sister I never had.
I understand the meaning of her words now. A journey is about connection, interaction, mutual respect. It's about each other. Not only about receiving, but also about giving. Now I need to find the connection. The woman that she always talk about.
Ini yang kamu dapat dari mana?
Oh, di sini. This one was given by my mother.
Kamu sudah tepat datang kemari. Nah, tujuan kamu ada beberapa kilo lagi dari sini. Kamu bisa jalan.
Selamat sore, Ibu.
Siapa itu?
Do you remember this?
Oh iya. Seren ya?
Yeah, I'm her son.
Yuk, ke rumah.
Yeah, it's been so long. I've been traveling all around you.
Under the starlight, we'll find
This is what Aceh has given me. A beautiful place with clear blue water and a diamond bright sands. Where kindness and comfort always here for me. A place that I call home. This is my first time in Aceh, and I know it won't be the last.
The light of Aceh, wonderful Indonesia.
Have you heard this story about a beautiful place? A place that makes you feel restful. In the midst of people who live in religious harmony. A place that makes you feel home, that makes you curious for more adventure. Start your journey. Travel to the place where the story unfolds. Feel the sea breeze caress your face and the sound of the waves breaking your consciousness. That you can see them through the beauty of woven fabrics. Or smell them through the scent of coffee that wafts in the air. If you have never heard it before, you may now find it intriguing. You may want to know every square inch of this place. From the beauty of its land to the depths of its seas. With an amazing biodiversity. Perhaps you've heard this story about a land which has traditions so diverse. Meet these friendly people who will with warmth. After all, welcoming guests is their tradition. The light of Aceh, wonderful Indonesia.